Good evening, all the aspirants. Here we have the speaker, Dr. Nikhilesh Jain, and the topic for today is Renal. And Dr. Nikhilesh Jain is the Director and Operational Head Depth of Critical Care Services at CHL Hospital Indore. So you may continue. Thank you.
Relatively simple thing to answer, dose of effluent volume of CRRT in patients of AKI in critical care. Everybody is answering D. Any particular reason? What we suggest is ideal actually, without assuming there are going to be no breaks or anything of any sort in an ideal world situation. Pika immediately corrected. Okay, so Christina got it wrong, but Pika corrected it. Lean has got it correct. So this is indeed the right answer. The dose of effluent volume of CRRT in patients of AKI in critically ill patient, what is recommended is 20 to 25 mils per kg per hour. This is standardized, it is given everywhere in the literature. So there's a no-brainer, you have to know this. The dose of effluent volume of CRRT in patients of AKI and critically ill is 20 to 25 mils per kg per hour. So which of the following values indicate pre-renal acute renal failure? Answers. This is again simple. This everyone has got it correct. And if I were to discuss fractional excretion of urea, then what would have been the variable that would have been discussed? We would have discussed something about diuretics, Last time we did it in one of the sessions. Okay. So here you have a patient of COPD who presented in this ICU with a PCO2 of 100, PO2 of 50, pH of 7.23 and bicarb of 36. So you can very well appreciate that there's a respiratory acidosis for which there's a compensatory metabolic alkalosis that is happening there. Now the patient was placed on NIV and was also nebulized with high dose of salbutamol. So the following reports came from the lab. Sodium of 140, potassium of more than 10, chloride of 111, calcium of 0.3, magnesium of 0.2, alkaline phosphatase 14, and the resident was confused. He called up the consultant and the consultant gave him the diagnosis. So what do you think has happened here? Oh, the pin drop silence. So difficult. Okay. For example, what else? Okay, I'll put it again. Everybody's sure it's D, huh? Any other answers? I'll go back to the answer slide now. Yeah. Because this is the second time you changed. Okay, now Salah has also come around. So the answer is indeed potassium EDTA contamination here. This seems simple. Which one of the following is not a cause of chloride responsive metabolic alkalosis? Correct. Venus has got it correct. So true. So the answer is E, because the urine chloride levels in primary aldosteronism are more than 20 milliequivalent per liter, unless there is an actual chloride retention happening at some other physiological level. All the other causes, if you look at it carefully, and I'll go back to them, they have all got chloride levels which are less than. Now, which one of the following is most likely to cause dialysis-induced hypertension? The option is most appropriate. Remember that. The option is most appropriate. Okay, Salah has answered C. No other takers. So the answer is actually here is a low calcium dialyzer. The answer is D. And 25% of interdiabetic hypotension happens with a rapid urea removal. It also depends on the choice of dialyzer and the dialysate composition. So if going back to the question, you get options like these, low calcium dialysate is the more appropriate thing. High sodium, of course, will never do. So high sodium is the most unlikely. Among the other three options, the most appropriate option would be a low calcium dialysis. So this is a question 6. In patient of acute kidney injury, these are the options. This can be attempted as both. You can pick and try to choose a single option as well, and you can pick and try to choose other options as well. You can make it into a K-type question as well. Neil, you have to put it in the options like Pika has done, something of that sort. So the answers are F. Wait a minute. There were two that we got actually, F triple TF and FFTTF. So the answer is FFTTF. I think Leal got it right. So that is what is correct here. Going back to the options, uh, serum urea and creatinine are not sensitive markers. So this is F clearly. It is not typical. Finely granular the cast is not considered typical of ATM. So that is one thing. And pre-renal ARF fractional excretion of sodium is typically, we covered this question before. And anemia is a typical finding. All those things, I think Lead only got it right. FFTTF. Lead only got it. So question number 7. 64-year-old male, history of cirrhosis, secondary to Hep C, is being evaluated for abdominal pain. This patient reports worsening generalized abdominal pain and fever for the past 4 days. He denies hematemesis of melena. BP is 110 by 60 mm of mercury. Heart rate is 95 beats per minute. His physical examination is significant for icterus, ascites, and generalized abdominal tenderness. Lab analysis is notable for white cell count of 18,000, creatinine of 1.1, blood urea nitrogen of 36, and total bilirubin of more than 4.3 milligram per deciliter. The patient received broad spectrum antibiotics, and which of the following drugs is most appropriate to administer to reduce risk of renal failure in this patient? I'll go to the options. You've gone to the question. Question is a large one. If you say yes in the chat box, then only I'll move forward to the options. First yes has come. I will move forward. These are the answers. So which option? This is a single option now. Which option do you think is most appropriate or most correct among all four? All are rating A. He has denied any history of hematemesis. Think about it. No hematemesis here. Huh? Okay. So the answer here is B actually. Albumin 1.5 gram per kg now and 1 gram per kg on day 3. How we go about it is albumin appears to be most effective in patients with serum creatinine more than 1 milligram per deciliter and total bilirubin of more than 4 milligram per deciliter. But its effect is unclear in those patients who have lower creatinine and bilirubin levels. If you look at the European Association for the Study of Liver guidelines, they talk about starting albumin infusion in all patients with spontaneous bacterial peritonitis. The recommended dose here is 1.5 gram per kg at the time of diagnosis and 1 gram per kg body weight on day 3. Terlipressin, midodrine, octreotide, they are all are used as treatment options for hepatorenal syndrome or probably with an ongoing variceal GI. So next question. 26-year-old, previously healthy, G1 gravida 1 para 0 female at 36 weeks gestational age, comes to ED because of polyuria, nocturia, and polydipsia. Her pulse is 78 beats per minute, BP is 102 by 63, and weight is 53 kg. Physical examination is normal except for decreased skin turgor and dry mucous membranes. Lab data reveals low urine osmolality to the tune of 89 milliosmoles per kg, serum osmolality of 308 milliosmoles per kg, serum sodium of 144, potassium of 4.1, chloride of 109 milliequivalent per liter, blood urea nitrogen of 10 milligram per deciliter, creatinine of 0.7 milligram per deciliter, glucose of 110 milligram per deciliter, and HbA1c of 5.3%. Serum ADH is zero point 0.5 picogram per ml. MRI of her brain demonstrates no acute findings. So which of the following statements best explains the symptoms? Have you all gone through this? I can push on to the options part. Sana has mentioned for the past question that Turley can be used for HRS and SBP. The point is not whether it can be used. The problem here is that you have to come to the most appropriate option here. So the most appropriate option in that setting would have been albumin. That was a single answer question, right? If everyone has gone through this, I can push on to the answers. Yes. So, so these are my options. What all could have happened? She may be having a kidney disease which is affecting renal sensitivity to ADH. She may have an ischemic insult leading to decreased release of ADH. There may be placental trophoblast producing excessive vasopressinase, and there can be an autoimmune destruction of the pituitary. So, what do you think is the answer? Any wild guesses? Any other answers? This is the third option. Now you're left with only one option. I've got B, I've got D, I've got A. So, unlikely as it may seem, all of you are actually wrong. The answer is C, and it usually develops at the end of second or third trimester of pregnancy. It will resolve spontaneously 4 to 6 weeks after the delivery. The pathophysiology, it's gestational diabetes insipidus. It is different from both central and nephrogenic DI, and rather than a deficiency in ADH secretion or decreased receptor sensitivity, it involves excessive vasopressinase activity. It is something new, so I have included it. Question 9. 63-year-old female admitted to ICU from another hospital, ongoing acute upper GI bleed, leading to multiple blood transfusions. She has got a history of previous CABG and end-stage renal disease. She's end-stage renal disease on dialysis. The records from the other hospital indicate that she was recently diagnosed with heparin-induced thrombocytopenia. She is due to get her dialysis today and feels short of breath after the blood transfusions. Now, what do you think would be the most ideal anticoagulation strategy for hemodialysis in this particular patient? And move on to the options. These are your options. It's simple actually. Correct. Unlike the previous question, everybody is getting it right. Sorry, excuse me. So this is correct. It is indeed regional citrate anticoagulation which can be used safely here. Answer is B. So you have another female with a history of hypertension and diabetes getting admitted to the ICU after an exploratory lab following a motor vehicle accident. Vital signs include tachycardia and BP of 90/66. She is currently intubated, mechanically ventilated, and she has developed acute kidney injury and requires renal replacement therapy. Now, this is anticipated that she may need several trips to the operating room in the next few days for debridement and subsequent closure of the abdomen. What do you think is the most efficient modality for renal replacement therapy for this particular patient? Right? So, shall I go to the options? So, these are your answers. What do you think would be correct? And this is a single option. Pika, think carefully. She has borderline BP. It's also a clue I'm giving to others. Right. So, Lean and Nidhi have got it right. It is indeed true. Pica also subsequently. But the thing is, what we are going to use here is prolonged intermittent renal replacement therapy, which will have, sort of the good parts of the, uh, hemodynamically stable renal replacement therapy and some portions of intermittent hemodialysis as well. So, PIRRT is a renal replacement modality wherein your treatment sessions would typically last for 8 to 12 hours, but are intermittent, about 3 times a week. It's basically a hybrid treatment wherein the hemodynamic stability, which is achieved with CRRT, is actually combined with the intermittent nature of the intermittent hemodialysis. Diffusion, convection, or a combination of the two techniques both can be used with this modality. It is specifically useful in those patients who are not hemodynamically stable enough to initiate intermittent hemodialysis, and they actually require several interruptions in therapy, potentially due to required procedures, which would make provision for a CRRT challenging. Because to be effective, we all know that CRRT has to be performed over 24 hours and you have to have minimal interruptions. Because PIRRT has scheduled time off of dialysis and anticoagulation, you can strategically schedule your procedures accordingly. Okay, I've gone beyond questions and I've taken up certain images, what I could find, just to enhance your understanding of a few things. So what I've depicted here are 4 types of dialysis, of course. First is SCUF, mainly stands for ultrafiltration, where there's no solute clearance and it is mainly used for fluid removal, right? CVVH, where it is used for solute clearance, convection is the method that is done. And if you look at it, I'll try to use the pointer here again. Let's see. So here, if you see, we are talking about replacement fluid here. This is your replacement fluid. It can be given either pre-dilution or you can be given post-dilution. And this is what the effluent comes through. When it comes to CVVHD, again, here the solute clearance is by diffusion. And the fluid that gets done is the dialysate. Again, if you look at it, this is how the access gets connected. This is how the dialysate gets connected. And this is how the return gets processed. Here, somewhere you get the effluent. You combine both, and what you get is CVVHDF, wherein you get a replacement as well as having a access and a dialysate connection here as well. So what is really happening here is, here you are having solute clearance by diffusion and convection. No voice, is it? Wait a minute. No voice. Am I audible?
Yes.
Okay, okay. Everybody is able to get my voice. Everybody got through what I just taught.
Voice broken in CVVSD.
Okay, fine. So CVVHD, if you look at it this way, what I've done is I've used line diagrams to enhance your understanding. Here, what is happening here is, if you can see it very clearly. Here, the solute clearance is by convection, CVVH. And what is happening here is you use a replacement fluid free and post dilution, simple as that, right? CVVHD, what you do is, access remains the same, you use a dialysate directly into the dialysate cartridge. Here, now you've got things which are combining both CVVH, CVVHD, and CVV, and then you evolve into CVVHD. Here, replacement fluid is also there. Here, you have an access here, and here you have a dialysate going directly into the dialysate. Here, if you look at it, in CVVH, the solute clearance is by convection. If you look in CVVHD, the solute clearance is by diffusion, and solute clearance, obviously, because it combines both, you have a solute clearance by diffusion and convection. Does this make it clear?
Yes.
Okay. So we go on to the next slide. And this is how you may get CRRT circuits differently. So this makes it slightly tough because CRRT is always tough. I think. Now, which one of the following statements regarding solute clearance in CRRT is most correct, you know. Again, remember that one option. Sieving coefficient for urea decreases over time, that is option A. Solute clearance is inversely proportional to the effluent flow rate, that is option B. Small solute clearance is equivalent for CVVHD and P-dilution CVVH if you use similar effluent and ultrafiltration rates. D, the sieving coefficient for small molecular weight molecules such as creatinine is 0. And last option is diffusive solute clearance is optimized if you have a dilysate to blood flow ratio of more than 0. Can I have the answers? Tough, easy. My God, there's silence. Okay, fine. No issues. So the correct answer here is A. You know, the sieving coefficient for urea decreases over the time. We'll go through the other options as well because I can understand something you do not do routinely. Even though the sieving coefficient for urea is 1, the sieving coefficient for urea decreases daily because there's a protein layering that keeps on happening on the membrane. B is incorrect because solute clearance is directly proportional to the effluent flow rate. C is incorrect because small solute clearance is equivalent for CVVHD and post-dilution CVVH, not pre-dilution, if you are using similar effluent and ultrafiltration rates. D is incorrect because sieving coefficient for small molecular weight molecules such as urea is 1. Now E is incorrect because the dialysate is not completely saturated when the dialysate or blood flow ratio is more than 0.3 and the linear relationship of increasing the dialysate to increase the solute clearance is lost, right? Anyway, I will be forwarding this PPT to Sana. So maybe you may get a chance to go through this question again, right? This is the bugbear of so many people. 100 kg patient and you have a CRRT parameter. CVVHDF blood flow of 100 ml per minute, pre-filter replacement fluid of 1800 mils per hour, dialysate of 1000 mils per hour, post-filter replacement fluid at 200 mils per hour, fluid removal at 250 ml per hour. Hematocrit is 25%. Can I have the answers? Or do we need options? I'll give you options. This is relatively simple that way. We'll go back to the scenario just a minute. And Pika has answered B. So we'll go back to the scenario. Here it is. So Pika has again changed answers. Hmm. Yes. Okay, fine. So answer is indeed C. Dose is defined by effluent rate by the patient weight. Here, if you look at the equation, it is 1800 plus 1000 plus 200 plus 250 divided by the weight of the patient, that is 100 kg. And this is how the variables work. So this is for CRRT prescribed dose. I'll try to give you something which may be simpler to understand and maybe something you can use much more easily. So total effluent fluid rate is a surrogate of solute clearance which is provided by CRRT, and it is actually used to determine the dose of CRRT in diffusive, convective and hybrid modalities. Now it is typically reported in mils per hour and it is adjusted by the patient's weight in kg. So the final value comes out to be mils per kg per hour, right? So when we talk in terms of the usual concepts, QB is your blood flow rate in mils per minute. Now the blood flow rate is the only one that is in mils per minute. Remember that. Dialysate rate or QD is mils per hour. QUF is the ultrafiltration rate, which is mils per hour. QR is the replacement fluid rate, mils per hour. QE is the effluent rate or mils per hour. Now, recommended minimal effluent dose is 20 to 25 mils per kg per hour. When we did the first question, somebody went higher up. They were not exactly wrong, but the most appropriate option would be 20 to 25 mils per kg per hour. Why we take a slightly higher target is because so many times, because of a lot of variables, we are not able to run the CRRT machine continuously. There are breaks into that. That is why you have to keep a slightly higher target so that your fluid removal target, your effluent dose target is reached. So dose is equal to effluent rate in mils per hour divided by patient weight in kg. Okay. So this is another equation which I could not make it in similar guys. This has, there's no such other thing that I could find more simple. Plus, CVVH, total ultrafiltration rate in terms of mils per hour, is pre-filter fluid replacement fluid rate in mils per hour, plus post-filter replacement fluid rate, plus fluid removal rate, and plus a pre-blood pump fluid rate in terms of mils per hour. That is how the calculation comes. For CVVHD, dialysate rate mils per hour plus a fluid removal rate will give you the answer. For CVVHDF, you have a total ultrafiltration rate in mils per hour plus dialysate rate, which is again in mils per hour, is equal to pre-filter. I think somebody no, is equal to pre-filter replacement fluid rate, that is mils per hour, plus a post-filter replacement fluid rate, again mils per hour, plus fluid removal rate in mils per hour, plus pre-blood pump fluid rate in mils per hour, plus dialysate rate in mils per hour. If you compare all the three formulas, you can put them together at one place and you can try calculations using that way. There will be certain questions in EDIC which would be coming based on this framework. And you may use this equation effectively to solve most of your questions. I've not framed any other questions to that effect because I believe they take a lot of time and you need to have a conceptual establishment for that. So one more thing we need to know, what is a CRRT dose dilution factor? So whenever you are using a pre-filter replacement fluid and or a pre-blood pump fluid, that is a PBP fluid, the CRRT dose is diluted and is therefore decreased. So what you do is the CRRT effluent rate is multiplied by the dilution factor and then divided by patient weight to reflect the actual CRRT dose in mils per kg per hour. And it takes into account the dilution that is happening because of the fact that you are using a pre-filter replacement fluid or a pre-blood pump fluid. Dilution factor is equal to plasma flow rate in terms of mils per hour. Plasma flow divided by plasma flow rate in mils per hour plus pre-filter replacement fluid rate in mils per hour plus a pre-blood pump fluid rate of mils per hour. That is the dilution factor. And when how would you calculate the plasma flow rate? Blood flow rate into mils per minute into 60 minutes per hour, minutes divided by hour into 1 minus hematocrit. Then comes another important term that we should know about is CRRT filtration fraction. Now, filter clotting is known to occur if your filtration fraction is more than 20 to 25%. So what is it exactly? It is the total ultrafiltration rate divided by plasma flow rate plus pre-filter replacement fluid rate plus a pre-blood pump fluid rate. Total ultrafiltration rate in mils per hour is pre-filter replacement fluid rate in mils per hour plus post-filter replacement fluid rate in mils per hour plus fluid removal rate plus pre-blood pump fluid rate. And I'm sorry, guys, there's a typo here actually. I'll just see if I can end the do a slideshow end and make it correct. Yes, this would look good. Yeah. So all of you are able to see this? Salah has asked, those can be more in hepatic patient and low in
Yes.
cardiac patient. So can be done, Salah, but it is very, very individual. And when you see so many variables, sometimes what your target has to be may have to be set slightly low. Some underdosing may have to be done. Sometimes you may need to do slightly more. So that is why there's a concept called PIRRT, which is coming into vogue now. If you ask me, probably running a CRRT machine with higher flow rates with for a lesser duration of time would be something that we may be looking at in the future. But of course, when we're going to give exams, it is purely operator dependent or what is the type of dose you want, right? So plasma flow rate in mils per hour is equal to blood flow rate in mils per minute. Again, blood flow rate is mils per minute. Remember that. Into 60 minutes per hour into 1 minus hematocrit. Please note that dialysate rate does not factor into your filtration fraction equation. It never comes into play here, right? Wait a minute. Yeah. Just a little bit of word about citrate toxicity. How do you detect it? Basically, the questions can come in terms of a rising anion gap with a worsening metabolic acidosis, falling ionized calcium levels, and total calcium is to systemic ionized calcium ratio becomes more than 2.5 is to 1, what you call classically as an increased calcium gap. Sometimes the question may come in terms of conversion. So if you want to convert your total calcium in milligram per deciliter to millimoles per liter, you can multiply your total calcium values by 0.25 and you will get it in millimoles per liter. Right? This is just one of the circuits I've shown. This is for a concurrently running ECMO and CRRT coming together. That can happen, right? In that, you have to separately look for an oxygenator. Okay, so this is again one of the questions. What do you see exactly here? And can you answer this question? Okay, one answer has come from Sala. Christina has said E. Deepa has said F. Any other options? So the answer is indeed F. You know, all of these are non-toxic. These are basically hemoperfusion cartridges of different types. And when they are not being used to remove poison or drugs, then for all forms of infective pathologies, hepatic failures, end-stage hepatic failures with aluminum intoxications, for all these indications, for cytokine removal, now these cartridges have come into vogue. So this is basically a hemoperfusion cartridge. A little bit of word about what are the differences and what are the salient points for pre-dilution and post-dilution fluid in CRRT? Because again, some questions may be asked out of it, or there may be some evolution of some MCQs by that. So pre-dilution fluid, whenever we talk in terms of CRRT, ultrafiltration rate, these are the advantages, you know. In black are the advantages and in red are the disadvantages. So in black is ultrafiltration rate is not limited by the blood flow rate. Illusion of urea from RBCs is enhanced. Filter life goes up as the hematocrit throughout the filter remains reasonably low, and you can actually it avoids the need for circuit anticoagulation. If you have a lifespan of a filter which is much more, then you can achieve a higher solute clearance over a long whole session, even though hourly solute clearance may be decreased. So these are the advantages. If you use a pre-dilution fluid. The disadvantages are solute concentrations go down because the concentration gradients are decreased in the countercurrent filter. So obviously the result is a decreased rate of solute clearance. So if you want to do that, or if you want to counter that again, more and more fluids, so a larger amount of pre-dilution fluid is required, which is a disadvantage. What about post-dilution replacement fluid in CRRT? Advantages are clearance of solute is directly related to ultrafiltration rate. You get a higher solute clearance rate. A smaller volume of replacement fluid is required for a post-dilution replacement fluid, and filter lifespan can remain unaffected if it is protected by adequate anticoagulation. Disadvantages: rate of ultrafiltration is limited by blood flow rate. You cannot ask for too much of fluid removal, otherwise the end filter hematocrit becomes too high, and that is why you use a smaller volume of replacement fluid. Now, ultrafiltration rate is limited by filtration fraction. Anything beyond 25% is too much. We discussed that. And one may not achieve the desired optimal dose of 25 mils per kg per hour with the normal blood flow rates of CRRT. That's what I discussed when I talked about PIRRT being the therapy and vision of the future. If it holds up to that promise, then filter life can actually be degraded by a high-end filter hematocrit. So all in red are disadvantages, all in black are advantages. So this is the next question. Okay, this is fairly simple, you know, you should be able to answer. It's simple. Everybody is zapped over. This is extremely simple. BP. Okay. Oh, sorry, sir. So the answer is actually C, that is effluent pump. This is the next question. Wait a minute. Given away the answer. Anyway, I'll finish this question fast because by default, the answer got leaked. But anyway, you got it here? Blood pump.
What is the answer?
Hey, you people missed out. I mistakenly did end of show, I mean, end of slide show, and the answer flashed below actually. So I was worried you got it right. And everybody has seen it. No, okay. So the answer to this is concentration gradient of crystalloid fluid. That does not impact your diffusion performance in CRRT. The dialysate flow rate, the molecular size, and the membrane permeability, all of them impact it. Now, these are certain values that you should know. There are certain alarms on CRRT machine about what are the cutoff values for the same. You should know about that. Access pressure is -70, return pressure is +90, and filter pressure is 350. Based on that, certain questions are formed in terms of where all can you get high pressures and troubleshooting. Yes. Can you answer this question? Again, this is simple. Everybody gets it right. This is indeed an abdominal pressure monitoring device. You do it through the Foley's catheter. And this is for monitoring through a Foley's catheter. And you have to know about the finer points of abdominal compartment syndrome whenever you are going to do it. And the intra-abdominal pressure cutoffs and their specific interventions and those cutoffs. This is going to be my last slide. Now, what you need to, sort of brush up in addition to the extra things, that you need to do is certain trials are there. You should know the finer points of those. What were the groups that were studied? What was the outcome that came? Then you have to know that what were the pressures used, duration. So these are finer points. There can be questions based on these trials. So you go ahead, read about them. And of course, timing of renal replacement therapy. That was my first class that I took in renal. That also becomes very important. There was a slide in that in which all the 6 or 7 trials wherein they've actually compared the timing of initiation of renal replacement therapy. All of them you should be thorough with. So that is all for today, guys. I think that is a lot in a way because CRRT is not an easy topic. I've tried my best to make it easier for you, but I do not know how successful I've been. This is the last slide for the day.
Thank you, sir, for the session. It was really valuable and informative. And we'll schedule the other class some other day. Thank you.
Sure. Thank you, Sana. And thank you, guys.